Welcome to a joint podcast from ACRO and the ROESCG Educational CME Committee. I'm Jessica Schuster. I'm an associate professor at the University of Wisconsin and the service chief at the Madison VA and a member of both committees. I'm really looking forward to talking about kind of the past, present, and future of the ABR and kind of the transition over time of the maintenance of certification. And we have some guests that are joining us from the ROESCG CME committee, and I will let them introduce themselves, and then we'll get started with our interview with Dr. Paul Wallner.
Well, thank you, Jessica. My name is Tarita Thomas. I'm one of the members of the ROESCG CME committee. I'm an associate professor of radiation oncology at Northwestern University and also part of the ABR Continuing Certification Advisory Board, or the MOC Advisory Committee. And look forward to this conversation with Dr. Wallner.
Hi, my name is Lisa Singer. Together with Liz James, I co-chair the ROESCG CME working group. I'm excited to be here today, and I'm currently an assistant professor at the University of California, San Francisco, where I treat breast cancer, lung cancer, and cardiac arrhythmias.
Hi, everyone. I'm Hina Saeed. I'm a radiation oncologist, deputy director at Lung Cancer Institute, Baptist Health, South Florida, as well as an associate professor at Florida Atlantic and Florida International University. I am a member of the ROESCG CME group. And today I have the pleasure of introducing Dr. Paul Wallner. I don't think he needs any introductions, and otherwise I can write pages of accomplishments, but I was told to be very brief by Dr. Wallner himself. So I would refrain from adding any more details other than stating that he is an associate executive director of ABR from 2009 until 2023.
Thanks very much, Hina. I really appreciate being invited to participate this afternoon. I think a little bit of context for the maintenance of certification programs is important. The board movement really began in the 1930s. The American Board of Radiology was incorporated in 1934. And when certificates were first awarded and up until the 90s, the certificates never said a lifetime certificate. It was always something of an individual construct. The certificates had the date of the award, but no termination date. So it became lore, accepted lore that they were for lifetime, but that was never actually the intent. It was never really discussed, but it was assumed. In the 1960s, the AMA began to really understand that there was some problem with the whole construct. And if you think about board certified, when we call ourselves board certified, that's past tense. So it means it happened in the past. I got certified originally in 1972. I have to think back now. That's a long time ago. So the AMA in the 1960s developed the CME program and the Physicians Recognition Award to try to stimulate some continuing education, if you will, but they recognized that that was not enough. There were pressures from legislators and regulators. So in the late 1980s, some of the medical boards actually stopped giving time-limited or non-time-limited certificates and began to give time-limited certificates. The American Board of Pediatrics in 1988 began to give an annual certificate. The American Board of Radiology, which I'll continue to refer to as the ABR, gave its last what was called a lifetime certificate in 1995 and began to transition into what was then called a maintenance of certification program. In 1998, the American Board of Medical Specialties, which was the umbrella organization for all of the medical specialty boards, the certification boards, began to investigate the issue of lifetime or non-lifetime certificates. And in 2000, the entire board movement accepted the fact that within the next several years, they would all transition to non-time limited certificates. So that, as I said, following 1995, the ABR certificates were initially 10 years cycling, but then with the Affordable Care Act and some pressures, again, from legislators and regulators, it was clear that a 10-year cycle was not appropriate. So the board movement has moved to a continuous certification, or now continuing certification process, where essentially it's a rolling 3-year process. Every 3 years, you have to attest that you've attained all of the 4 parts of the maintenance of certification or continuing certification program. So that the first of the MOC exams was administered by the ABR in 2007. And then for several years, we began to develop a modality exam where individuals had the ability to select what they wanted to be examined in if they were site specific. But then in 2020, the board moved to the OLA, or the Online Longitudinal Assessment Program. So there's no more exam.
Before we get into kind of the current, Dr. Wallner, can you tell us some of the obstacles that you maybe, or some of the feedback in the closed door rooms of changing from a 10-year certification to the online longitudinal assessment?
Well, actually, the feedback we got from the MOC exam, it wasn't closed door. It was actually very public dissatisfaction with the maintenance of certification exam. And I can understand that, because if you look at the data that we have from various surveys that have been done in the profession, about 30 to 40% of our practitioners site specialized. The problem with that is that certification, the ABR certification in radiation oncology, we're one of the few specialties in medicine that doesn't have subspecialty certificates. So our certification is general, which means that it's everything from pediatrics to brachytherapy to things that many of us don't do anymore. Only 5% or fewer identify as doing pediatric radiation oncology. So the MOC exam was felt to be very disconcerting. People were terrified by it. They were studying for it. They were taking time to study. At one point, they had to travel to the site centers, the testing centers. The feedback we've gotten from the OLA program has been really terrific. When I did it every Monday morning, even before I got out of my pajamas. I would do my 2 OLA questions, so I'd be finished by July. I could do it in the privacy of my home office. It took me 5 minutes or less to do it. I could give feedback, and we've gotten, plus it is what's called summative and formative. If I got something wrong, or even if I got it right, I was able to review the references. I could review the rationale for the response. So it was really very much more appreciated, and I didn't have to travel for it. So people really seemed to like it.
So when do physicians really have to start this OLA? How many questions are there, and how often do questions need to be answered?
When you finish your residency program, radiation oncology trainees are eligible to take their certification exam the year following their completion of training. And immediately upon certification, in that following year, you will get a letter that you've enrolled into the continuing certification program, and you begin to get your 2 questions pushed out once a week. You have to complete 52 items each year, so you can pick a question, you can pass questions, you can stash questions for up to 8 weeks. So there's a lot of flexibility in the program.
And Dr. Wallner, so in terms of the CME credits for the ABR requirements, how many are necessary to continue with the certification?
The ABR did not want to make CME an onerous achievement. So they basically stick with what most state boards, a lot of hospitals, the Joint Commission are doing. It's 75 credits every 3 years. And in 2023, just as of December 31st, 2023, self-assessment CMA is no longer required. And that's true for the entire ABMS board movement. And the reason for that, it really makes sense because the OLA exam is a built-in self-assessment instrument. So it seems silly to require essentially double dipping of self-assessment. And the only reason that self-assessment does was because there was no self-assessment prior to that for CME.
Could you discuss participation in OLA versus the historical essay CME? Have you seen participation rates go up?
The rates are pretty much the same as they had been because the continuing certification, or MOC, was required. But what we've seen is now there's really terrific data. I actually pulled up yesterday the data. The board is now reporting on a 6-month rolling basis the data. And as of December 31st, 2023, there had been over 115,000 items that had actually been responded to by 3,400, by almost 3,400 diplomats. So if you look at starting July or January 1 of 2020, the board has now over 900,000 data points for responses. And the board and we had begun to assess strengths and weaknesses. I had always wanted to do strengths and weaknesses at the site-specific level, but the board hasn't done that yet. They're trying to develop additional data, but they've done it for things like treatment planning. If you look at some areas of strengths and weaknesses, areas of challenges, there were in areas of bioethics, interpretation of evidence-based research results, and patterns of failure, were areas where diplomats were not scoring well on OLA. I might add, by the way, I'm on the ACRO Education Committee, and they're beginning to use some of the ABR data as needs assessment for development of CME programming. And that information is available to anyone who wants it. It's publicly available information as gap information for program development.
No, Dr. Wallner, I think that's so interesting. And as many organizations, I think, are challenged to share what is happening to the data. And so it is nice to know that, unfortunately, you could try to push it out in an email, but it's nice to know here. And I think hopefully it'll be important for our membership too, just to be like, yeah, it's nice to know that once I submit the question and I miss it, how many other people are missing it? And then having our national feedback loop to the national organization is really kind of the ideal. Where there's weakness, there should be education sessions, and having this nice loop. And personally, having done the OLA, I really appreciate the reference material in the individual questions. One small little follow-up question, since it sounds like you guys are looking at the data, the little 3 feedback questions that ask me how competent I am and do I think it's relevant. Is the board starting to dig into those?
Absolutely. The associate executive directors look at every response, and I actually reviewed that not on a daily basis, but almost a weekly or bi-weekly basis. And there are a number of potential responses. If the respondents feel that a question is written badly, it is referred back to the committee to either rewrite or to scrap it entirely, to retire it. If too many people feel that it's not part of their practice, The board revisited that to see whether it should be retired or whether it should be put in a separate pool. One of the questions that remains is whether the board should begin to develop more site-specific OLA questions. I'd like to do that. I think there's enough. I mean, if you think about it, you have to have a fairly good inventory of items to be able to do site specificity. If you tell me your practice is 50% or 60% GYN, when we did the modular examination, by the way, there were 200 items, and of those 200 items, you could select 60 items self-selected from 2 modules. You could select 2, let's say if you did only GYN, you could select 2 GYN modules or 2 breast modules, but the rest of the exam, 140, were general, because again, we certify and recertify and continuously certify in general radiation oncology.
Thank you for sharing that. That's really an interesting and thought through process of how you're going to use that information. What changes do you think might be coming as there's a transition from the MOC to continuing certification?
Well, some of the changes have already been made, and I think the ABR and the ABMS movement in general is committed to trying to keep the changes to a minimum. One of the things that diplomates were upset about was there seemed to be a lot of changes in the program. So some of the things that have been done over 2020, 21, I mean, one can argue that the pandemic reduced our travel schedules a little bit, so we had more time to think about some of these things. So items where you had to present documentation, part 1, part 2, and part 4, where you had to actually present the documentation, are now self-assessment or self-documentation, self-attestation, I'm sorry. So you only have to attest the fact that you've completed those. The issues in part 4, especially for the projects, have been made much easier. And now it's not just projects if you choose to do a project, but participation. And I would suspect that each of you in your various facilities participate in QA meetings or peer review meetings or morbidity and mortality meetings. And those are considered as part of PQI, as part 4. So that's been made a lot easier. It's been made easier and will be made easier for private practice people to do PQI projects. People who are in individual practices were finding it difficult to do peer review or QA and QI sessions. So that's been made easier. The OLA can't be made much easier. The questions are pushed out regularly. I think the big change there will be to push out more information over time so people will know how they're doing compared to their peers, and for organizations that provide educational programming to have more information regarding gap needs.
Thank you for sharing all of those transitions from SACME to OLA and also the transition to continuing certification. Could you talk about some of the challenges with the current system?
Well, I think that you can discriminate between challenges and pushback. I think the pushback that the board gets from diplomates are the cost, number one, and whether it's necessary. And that's a big issue of pushback. Can you prove, if you will, that continuing certification or maintenance of certification is an improvement? That's a difficult to construct to prove, because theoretically, if you were doing a controlled study, you take people who are in maintenance of certification and compare their performances to people who are not, and that's very difficult to do as time goes on. If I were not in MOC or continuing certification, why would I want to have myself challenged, if you will? So it's hard to prove the negative in that regard. The issue of cost, the board, the ABR, and none of the ABMS member boards are for-profit. They're all not-for-profit. The ABR has finances in reserve, but they're all committed to future projects. People think that the board is just raising a lot of money. It's not. The board salaries are not high for those limited people who are staff. Really, the bulk of the work for the ABMS and ABR board movement is by volunteers. As some of you know, some of you volunteer to assist in the board for writing questions or being examiners. Before I was a part-time employee, I was actually an oral examiner, and that was all gratis. No, you're paid your expenses, but nothing more. So the board has a huge amount of volunteer time. I think there's less and less pushback over time because more and more diplomats are in the movement. And as I joked when I spoke at a SCARAP meeting about MOC once, and very few of the SCARAP are obviously the academic chairs, very few of them were in participating in maintenance of certification. And as I said to them, and they weren't all amused by it, that we had a life insurance actuary who informed us that that was a self-fulfilling prophecy, that it would solve itself in the not too distant future as the chairs either rotated from their positions or dropped dead.
Yes, sometimes people just age out.
Right, exactly. So now I think more of the diplomats are used to this. They don't find it an onerous experience. It's been a part of their everyday lives since the day literally they became certified. So there's very little pushback, really, more and more.
And you're talking about pushback in a kind of practical sense. If there were things that we as diplomats or end users wanted to provide feedback, what are the avenues in which providers, participating in the OLA and the continuing certification could provide feedback?
Well, you're welcome to reach out to the new Associate Executive Director for Radiation Oncology, Michael Eunice from Springfield, Massachusetts. There are 4 radiation oncology trustees who are all, I can tell you who their names are, they're all on the website. And one governor, Andrea Ng from Brigham and Women's, is the governor, senior leadership of the ABR. The 4 trustees are Steve Frank from MD Anderson, John Sue from Cleveland Clinic, Kate Yashar from UC San Diego, and Brian Davis from Mayo and Rochester. And they're all open to hearing suggestions. They're all willing to consider changes. And I will say it is an urban legend that all of these decisions are made by diagnostic radiologists for radiation oncologists. I can tell you that's absolutely unequivocally not true, that all the decisions for the radiation oncology candidates and diplomats are made by radiation oncology trustees and radiation oncology committed staff.
And it was so helpful to know that, when I comment about a question, that it is going somewhere as well. Because like at the end with those extra questions, that there's somebody reviewing like, I didn't think this was the best question, or I thought there were 2 answers as well. So I have one additional question as we've been pondering this that I don't think we necessarily even thought about in advance, but I'm sure you have some thoughts on it. What happens when a provider forgets to do it? Just deletes all the emails, or, kind of what are the warning bells before they realize that they're kind of in trouble?
The board does a regular and annual review, and on a rolling basis, I believe the date now is by March 31st, we'll push out to each diplomat their status. And for the most part, if you are behind, you can catch up. The certification is annualized, but, and this is a little confusing, it's on a 3-year rolling basis. So every 3 years, essentially, you have the ability to catch up. So it's really very difficult to fall behind. I mean, and there are always circumstances. We've had occasional diplomats who are in the military reserve and have been out on deployment for a year, and they simply complete a special circumstances request, and the AED, the Associate Executive Director, considers it and typically will grant a special circumstance waiver. So there's a lot of flexibility in that regard. didn't like to hear the dog ate my notes or those kinds of issues, or oops, I forgot to do it for the last 3 years, but that's very rare.
I lost your email address, password for
Right,
2
exactly.
years, right?
Exactly.
Dr. Wallner, can you speak a little bit about the questions themselves, how the questions are developed? It was great to hear about how how the information is being used for continuing education, but it'd be great to hear about how they're developed.
Sure. When the MOC exam was begun, the rule of thumb was walking around knowledge. And if you Google walking around knowledge, you'll probably get nothing because nobody could figure out exactly what it was. There were a gazillion definitions of walking around knowledge. And at the end of the day, since I had to basically make the final decision, I said if I did head and neck and lung, which were my primary sites of interest, and I was walking around or was having lunch in the hospital cafeteria, and a medical student came up to me and asked me a question about GYN radiation, I could answer it. That was walking around knowledge, that it was something essentially that I didn't do every day, but that I could respond to. And initially, when the OLA program was first initiated and we needed a new inventory of items, the original exams, the original MOC exams were simply pulling questions from the initial certification exam, and they were quite difficult. So we stopped doing that. For OLA, we actually were having the same committees, the same site specific committees doing the first year of OLA questions. But early on, we realized that those people were site specific in their own right, and the questions were too tough. So that now there is a freestanding OLA committee. They're all generalists. They're all, for the most part, younger, early career or mid-career practitioners who are doing general radiation oncology and have a sense of what you really need to know as a generalist. Again, the ADs and the trustees review. I gave reports to the trustees at every trustees meeting on the feedback we were getting from the diplomates in the field. So we knew whether questions seemed to be too tough, whether they were irrelevant, whether they felt they were too specific. And that feedback was used to inform the OLA item development committee as to the quality of those items.
Thank you so much. I feel like that was a very comprehensive review. And I think we said this, but I thought I would close kind of with, when is it that OLA officially starts for people in their timing of being post-resident and transitioning into being a faculty or a private practitioner?
Yeah, I think I don't want to give you incorrect information. There was some question whether it was essentially the day you got your certification or January 1 of the following year. It may be January 1 of the following year because certification is now available, since the certification exams, initial certification exams, are given twice a year. We started doing that again to give people more options in family planning and vacations and all kinds of other issues. We started that in 21, I think, 2021. So there now are 2 sets of board certification. So I think it's actually January 1 of the year following your certification. But don't send me nasty notes about that. I would check that on the website.
All right, everyone listening, double check on the website.
Right, double check on the website.
So that brings us to the end of kind of the questions that we had wanted to cover. Give a quick opportunity to our panelists if they had additional questions. And while they're pondering, I think that they may have asked and gotten answers. But Dr. Wallner, kind of in the last couple closing minutes, do you have any words of wisdom or final thoughts that, having been a part of the ABR for a very long time, that you would like to share with your fellow radiation oncologist?
Sure. I think there is a misunderstanding of the nature of certification, number one. I think the whole issue of lifetime certification really was an aberrant construct, that it's critical for us to keep up. And we all know, we've seen there is very good academic literature about how long it takes for practitioners in the field to adopt evidence-based practices, and how our knowledge base declines over time, and how our practices change over time, how disciplinary actions increase over time. So I think the issue of continuing certification and maintenance of certification is important. I think it's also important for people to realize that board certification remains the single most important credential that physicians can have. I mean, everyone, when you see a new patient, they don't ask if you've graduated from medical school. They don't ask, I never in 50 years had a patient ask where I stood in my class, and remembering that half of the doctors practicing were in the lower half of their class. But they do ask if you're board certified. And that's what they look at, because that's the single most important qualification that people consider. Another important consideration is, except until recently, regrettably, legislators and regulators have stayed out of the practice of medicine. We've been allowed to self-regulate, and that is a very important aspect of medical practice, to let doctors manage the practice of medicine. And board certification is an important part of that process. The board has aimed to make it as minimally onerous as possible. They've given out more information about the status of the exams, about the percentage of items in the various domains. They've helped to create study guides. They've indicated that information that's not in the study guides won't really be included in the exams. They've tried to keep the cost of the exams stable. We recognize that it is a hardship, but it's not a cheap process to develop these exams. So I think people need to consider the impact of board certification and what it means to each of us in our daily practices.
Wonderful. With the closing thoughts, that will conclude our fantastic interview and history of kind of past, current, and future of ABR. Great thank you to the ROESCG CME committee for helping host and organize, Dr. Lisa Singer and Dr. Liz Jeans. And thank you to our guest panelists, Dr. Tarita Thomas and Dr. Hina Saeed. And Dr. Wallner, of course, our hats are off to you. Thank you for being the trailblazer, and also for your passion and persistence through something that nobody loves. You know, it's like the kicker. They expect you to do it perfect, and they only really remember your name if you're doing it wrong. So we appreciate you many, many times over for holding that role for such a long time.
Thank you very much. I appreciate those kind comments. I had been through enough ADROP meetings to know, we checked for vegetables at the door to make sure they didn't have tomatoes to throw.
That's right. That's right. Wonderful. Thank you so much.